So motion of this debate, as you see, that we do not really need surgery in non-metastatic transitional cell carcinoma of the bladder. And we have chairperson for this session, Dr. Bikash Agarwal, who is a consultant oncosurgeon at Apollo Multispecialty Hospital. So I would like to invite Dr. Bikash to get onto the podium and take over from me, please. Over to Bikash. So we have two speakers. For the motion, Professor Ananya Choudhury is going to talk about, and against the motion, we have Dr. N. Raghavan. And Professor Ananya Choudhury is a clinical oncologist at Christie NHS Foundation Trust. And she joined Christie in 2008, and she specializes in bladder and prostate cancer. And she has been lead clinician for advanced radiotherapy, including MR-guided radiotherapy program. And she is also the group leader of the Translational Radiobiology Group within the Division of Cancer Sciences of University of Manchester. And Professor Choudhury currently undertakes research and aims to optimize and personalize radiotherapy using new techniques or imaging technology. And she also has a number of national and international leadership roles, including chair of the Royal College of Radiologists, Faculty of Clinical Oncology, and editor-in-chief of BMJ Oncology. Now I'd like to invite Dr. Choudhury to make your presentation, please.
Good afternoon, everybody. Thank you so much for inviting me to be part of your symposium today. I'm really excited to talk to you, and I just wish I could be in Kolkata as well with you all. But I have been given the title, We Do Not Really Need Surgery in Non-Metastatic Muscle-Invasive Bladder Cancer. And no disrespect to my hosts, but I think the title isn't quite the title I'm looking for, because we will always need surgery in non-metastatic muscle-invasive bladder cancer, because at the very least, we will need my surgical colleagues to provide material, either in the form of a biopsy or a TURBT or a urine specimen in the future, so that we can actually make the diagnosis and potentially do molecular studies to ensure that we are personalizing the treatment. So I have changed the title somewhat to trying to convince you that surgery is no longer the gold standard of treatment, and therefore there is a very important role of non-surgical treatment of bladder cancer with radiotherapy. These are my conflicts of interest. So there is a lot of data out there that shows that we are doing our patients a disservice. There is an underutilization of radical treatment. This is data from the US and the UK, showing that as people get older, and if they come from poor social economic backgrounds, they are less likely to be treated appropriately. That can be less use of radical treatment or appropriate metastatic treatment, and a lot of these patients get no treatment at all. And this, I think, is a major challenge for those of us who treat bladder cancer and should be the focus of a lot of our work. So significant numbers of patients don't receive radical treatment, even if they're eligible. We also know right across the globe that bladder cancer patients are poorly served when it comes to the patient experience. This is data published last year, and what it shows is that it doesn't matter which country you look at. These are countries from all over the globe surveying patients and their carers. And what we see is that compared to other cancer patients, and here I think most of us treat prostate and bladder, so if you compare them particularly to prostate patients, bladder cancer patients are less likely to have support, less advocacy, less likely to have help with finances, and less likely to have help with long-term toxicity related to treatment. So what should we do about it? Well, the first thing I think we need to do as a community is actually have a meaningful discussion about the various options for these patients. And with that in mind, I'm hopefully going to show to you today that surgery is definitely no longer the gold standard. And I have to admit, in my practice, in my training, it never has been. And there is lots of data out there. There's data over decades showing that if you compare patients who have surgery with patients who have radiotherapy, and you adjust for known prognostic factors, that there is absolutely no difference in outcome. And a lot of this data actually is from the era when we used to give radiotherapy without a radiosensitizer, and surgical techniques, I appreciate, have become more advanced in that time as well. What I think is interesting here to note is the forest plot on the right side from the meta-analysis that was published in 2015, comparing radical cystectomy with trimodality treatment or bladder preservation treatment. And here, what the authors showed was that if you compare both these treatments, TMT is actually superior to surgery alone, even when you add in neoadjuvant or perioperative chemotherapy. And I think that's a thought I'd like you to keep hold of, because I will come back to it later on. And last year, what we saw was contemporary data from multi-institutions, high-volume institutions, but multiple institutions in North America, showing that when you compare surgery with non-surgical radical treatment, there is no difference at all between cancer-specific survival, disease-free survival, but there is a difference in overall survival. And again, remember that, because I'll come back to it. And what was really interesting about this data set is, first of all, it was contemporary. So it allowed the use of neoadjuvant chemotherapy, modern techniques for both surgery and radiotherapy. These were high volume centers. So these are the centers that we're all trying to emulate. Salvage cystectomy rate was 13%, so it's not that high. And actually, this is in line with data that's been published over the years from lots of different institutes, showing that salvage cystectomy is somewhere between 5 and 15%. And secondly, what was really important about this study is it was written by a surgeon. The first author, Professor Zlotter, is a practicing urological surgeon. And so he is convinced. You know, you don't need me to tell you that the outcomes are comparable. One of the surgeons is telling you this as well. And I'm very pleased to say that actually all this advocacy by so many people over the years, including patient advocates as well, means that the role of bladder preservation with neoadjuvant chemotherapy has now made it into important international guidelines. Here, I'm going to beat the drum of the NHS in the UK. We were the first guidelines to give parity between radiotherapy and surgery and advocate the use of neoadjuvant chemotherapy for all patients who are suitable. But it's great to see the Americans have caught up with us. So some of you are going to tell me that, you know, until we have level 1 evidence, until we have a randomized controlled trial comparing surgery with radiotherapy, you're not going to be convinced. But you know what? If that's the level that you're looking for, then you really have to try and deliver such a clinical trial. In the UK, we actually tried almost 20 years ago, and we failed. We could not deliver a randomized controlled trial of cystectomy versus bladder preservation. It was called SPARE. It failed to accrue. And it's interesting to think about why it failed to accrue. It actually failed to accrue because we all have our biases, and we could not deliver information in an unbiased way to our patients, which then influences the patients. But interestingly, patients also had their biases. A lot of patients who understood that we did not know whether surgery or radiotherapy was better chose to go with radiotherapy and did not want to be randomized, because who doesn't want to keep the bladder that they're born with? So we are left with retrospective studies and population databases that give mixed results, are limited by confounders, and I would argue that's the best evidence we're ever going to have. If anybody else wants to try and do the randomized control trial, that would be fantastic, but we're not going to do it in the UK. And I suggest we're not going to do it in many countries. But we can learn some things from SPARE. There were less than 50 patients recruited over 3 years, but those patients were randomized, and it does allow us to compare the quality of life within a randomized control setting. I know that Vedang and colleagues have recently presented quality of life from their patients, and that shows some interesting results. And in the UK, we've done a prospective quality of life study, which will be presented at ESTRO by my colleague Ashok Nikopata. But this is the data from the SPARE study. And what you can see reassuringly for my surgical colleagues is that there is very little difference in quality of life for the vast majority of measurable parameters, except body image and male sexual problems. And for the patients within SPARE, radiotherapy gave them a better body image, and for the men within the study, they were more likely to attain sexual potency compared to surgery, even if everything else was equal. This has also been shown in data from the US, where when patients who had radical cystectomy were compared with patients who had bladder preservation, body image, appearance concerns, life interference was all better with radiotherapy, resulting in less of a negative impact of the treatment on the patient's life. And interestingly, and maybe this is something that the surgeons need to think about, or at least the American surgeons need to think about, patients who had bladder preserving treatment felt they had more information and were better placed to make an informed decision compared to patients who had surgery. But what about all those patients who failed, you say? 13%, 1 in 10 in the Zlotta study. Well, they go on to have salvage cystectomy. And what we have seen locally, so this is Manchester data, that salvage cystectomy is required in about 1 in 10 patients treated with bladder preservation. But when these patients undergo primary cystectomy, then their outcomes are very similar to the patients who have primary cystectomy. So I'm going to tell you there's little to be lost. If you're a patient with muscle invasive bladder cancer confined to the bladder, why not have bladder preservation? There's a 1 in 10 chance that you'll get a local recurrence without metastatic disease. And if you're in that 1 in 10, you can go on to have an operation with no impact on your cancer-specific survival. It's a win-win, isn't it? Now, many people believe that there are a number of factors that impact on treatment choice for the patient and also the recommendations that we give as clinicians. A lot of people will say that these are very, very important predictive factors and should actually be used to select patients who are suitable for radical cystectomy or bladder preservation. I'm going to argue that there are only 2 factors that should really push a patient towards surgery. One is poor bladder function. If your bladder isn't functioning well, then actually surgery may well be the best treatment for you. And secondly, if patients have very active inflammatory bowel disease or have had recent high-dose pelvic radiotherapy, because we do need to leave time before we retreat these patients. Having said that, I have treated patients with poor bladder function, inflammatory bowel disease, and who've had previous radiotherapy, all with bladder preserving treatment with good results. So none of these, I think, are a deal breaker. Other factors such as hydronephrosis, T3, T4 tumours, or even multifocal tumours, I believe are prognostic factors, and these patients do worse whether they have surgery or radiotherapy. And that's what we need to discuss with the patient. Evidence for neoadjuvant chemotherapy. Well, the best evidence for neoadjuvant chemotherapy comes from the MRC BA06 trial, which was a UK wide trial from the 90s. In this trial, almost 900 patients were randomized to neoadjuvant chemotherapy or not. And then those patients went on to have either radiotherapy alone, because this was in the era before radiosensitization, or cystectomy. And as you can see, maybe because it's a UK-based study, almost half the patients had surgery and half the patients had radiotherapy with similar response rates. What was interesting is when the authors looked to see if there was an interaction with neoadjuvant chemotherapy by radical treatment modality, there was no interaction, which means that neoadjuvant chemotherapy was equally good at improving overall survival, whether the patients had surgery or radiotherapy. But what about in the era of radiosensitization? This is data from the BC 2001 study. This study was recruiting while neoadjuvant chemotherapy became a standard of care in the UK, and therefore a subgroup of patients had neoadjuvant chemotherapy, as well as being randomized to radiotherapy alone or chemoradiotherapy. And what we see from this data is there is still an improvement in outcome in patients who have neoadjuvant chemotherapy as well as chemoradiotherapy. So chemoradiotherapy is not taking the place of neoadjuvant chemotherapy. This isn't powered in any way, shape, or form to test the role of neoadjuvant chemotherapy alongside chemoradiotherapy. But I suggest again, we're never doing that study either, because the world has moved on. So this is the best data that we have. It's really important to use a radiosensitizer to get your optimal outcome for bladder preservation. It doesn't really matter which radiosensitizer you use, I don't think. Commonly used radiosensitizers are cisplatin, low-dose gemcitabine, carbogen nicotinamide, and mitomycin C and 5-FU. And as you can see from all this data, if you use a radiosensitizer compared to radiotherapy alone, you get better outcomes. The advantage of having lots of different radiosensitizers is there's a radiosensitizer for every patient. So going back to my starting point of we need to be better at giving appropriate treatment to appropriate patients, having a range of radiosensitizers allows you to do that. We also know that radiosensitization, whether it's with hypoxia modification or with chemotherapy, produces meaningful long-term outcomes and cure. This is 10-year data from both BCON and BC 2001. And as you can see, even out to 10-year follow-up, and these are elderly patients, right? The median age was over 70. Even out to 10-year follow-up, these patients get meaningful cure and good outcome. So we should really be considering this treatment for our patients. And it would be good to see comparable surgical data out to 10 years as well, just to make sure that we're getting similar outcomes from surgery as well.
Professor Chowdhury, sorry to interrupt you.
Yeah.
I would like you to sum up your presentation, please, so that the other doctor also can present his slides.
Oh, okay. Sorry, I hadn't realized. I thought I had longer. But let me sum it up for you then in this way. Overall survival is better in contemporary data sets than surgery. And I think the surgeons need to help us try and explain this if they're going to maintain that surgery is not just the gold standard, but equivalent to modern radiotherapy. And I think actually bladder preservation could be better than cystectomy. That could be better because outcomes can be improved with neoadjuvant chemotherapy. because we can hypofractionate and give higher doses per fraction than 2 gray, which reduces overall treatment time and improves outcomes. We have advanced radiotherapy techniques, such as daily adaptive radiotherapy or MR-guided radiotherapy, reducing overall treatment times with shorter neoadjuvant chemotherapy and shorter radiotherapy times improves outcomes because bladder cancer is a rapidly proliferative disease. And as we learn more about predictive biomarkers for better selection of our patients, we can also improve the outcomes in that way. So I go back to the best bladder to have is the one that you are born with, and that means that radiotherapy is absolutely an option that should be discussed with our patients. Thank you.
Thank you very much, Professor Chaudhary. So we have Dr. N. Raghavan, who is a surgeon specializing in urological surgery. So to present his side, we will be speaking against the motion. Dr. Raghavan is an alumni of PGI Chandigarh. He was trained and worked as a senior consultant urologist and uro-oncologist in UK. And he did a fellowship in Germany. And he has more than 15 years experience working in uro-oncology with expertise in various techniques like open, laparoscopic, and robotic surgeries. And he's the first in South India to perform novel and pioneering works in robotics. So Dr. Raghavan is going to speak against the motion. And so I just now invite Dr. Raghavan to make his presentation, please.
Okay. Thank you so much, organizers, for this afternoon. So this is the GU Cancer Meet in Kolkata, India. I just have to remind everybody about that, and that this is not UK, whilst I was there as well, and many of us were there in UK. Hi, Professor Ananya. So nice to catch up with you. So whilst we were planning to go to Lakshadweep, the way our Prime Minister has encouraged us to do, I get a phone call from my very good colleague, Mohammad Zairan. Ananya will know him as well, who is a clinical oncologist in Apollo, Chennai, saying that he has a 70-year-old with that tumor and hematuria, and what is he supposed to do now? Professor can give us some answer. Professor said we can take some Bellara chips and give it to her, which I'm very happy to do, but outside people tried it. They took only 2 chips and gave that. That's not going to work, isn't it? I completely concur with the professor who's kindly agreed that the debate topic itself is not very appropriate time. I was very happy when the topic came. Surgery is obsolete. I thought, wow, Lakshadweep for me now. But sadly, surgery is not obsolete. Surgery is very much there. So I don't need to prove surgery is essential. In fact, it is the other way. Yeah, the radiotherapy have to prove themselves as equivalent. Surgery has been there time immemorial. So couple of disclaimers. I'm a surgeon. The question is, can TMT replace radical cystectomy? That's a question, yeah? And answer, all of us know, in selected patients, answer is yes. The problem is, when you have selected patients, it's like surgery is there for every patient, TMT is there only for selected patients. That's the point here. That's the clue. You cannot say surgery is replaced. There is so much of social media activity, Twitter, but in real life, patient walks in with that tumor. Everybody sitting in this room would have seen the tumor on a daily basis and think what to do with them, 9 centimeter, 10 centimeter tumors. That's EAU guideline, very clearly saying that if it's a T2 to T4 disease, surgery is always an option, and in selected T2 patients, radiotherapy is an option. Yeah? So let us think about some critical questions. When you ask a selected T2 patients, are all patients T2? T2? Question 1. paper clearly shows that in 54% of the patients there is upstaging and they are not T2. And in about 26% of the patients they have node positive disease. And many radiotherapists don't cover the nodes, only off late we are covering the nodes in the radiotherapy, especially whole pelvic RT came through. The EAU meeting, very important, said there should not be carcinoma in situ. So let's ask another question. How many of the patients have concomitant carcinoma in situ? 1,000 patients assessed, 26% have carcinoma in situ. Once again, they are not eligible then, isn't it? Okay. Then we ask another question. The patient should not have hydronephrosis. How many of you practicing in India have come across patients who have a tiny muscle invasive bladder cancer in one corner of the bladder? Almost nil, isn't it? Those are very nice patients. They have a T2 or a T1 disease, G3, TA, who have BCG. Inevitably, we get large tumor occupying the whole bladder. Both the UOs are not seen. You put nephrostomies, creatinine is 4. Yeah? Comorbidities. Comorbidities, whenever you get, the problem is, if you get a fit and well patients, they do well. Either you do radiotherapy or radical cystectomy, it doesn't matter. They are good performance status patients. They will do anything you do. And if you're going to put a very poor comorbid patients through cystectomy, they are not going to do well. We all know that as well. So many of us in India, including Sanjay and Shrivats, who are all here, have adopted the strategy. We have realized that it is the ileal conduit diversion which makes all the difference, and we have now realized that without doing ileal conduit diversion and doing primary ureterostomy, we get away with these patients as well, giving them a fantastic recovery time from the cystectomy. A lot of discussion in social media about bladder preservation protocol, or the oncological outcomes are equivalent. Answer is, I'm very happy. I'm very happy that patients are now having an alternate. We have an oncologically equal outcome or equal for bladder preservation protocol as well. I'm very happy, but cystectomy has time and again stood the test of time, for time immemorial. Whether a surgeon writes a paper on this, very happy. See, surgeons are very nice people, you know. We write paper on radiotherapy. We are happy about that, okay? But the fact is that when a patient is going to live beyond 10 years, it's the surgical patients who live beyond 10 years, not the other way, yeah? And we also have to think about salvage cystectomy. When we say salvage cystectomy, if you think about it, patient had a tumor, you give radiotherapy, that patient would have lost the bladder, he may not have had a recurrence. The salvage cystectomy is meant for only local recurrence. A volume of patients had metastatic disease and they died, which is not accounted at all. We all agree, T3 disease, we all know that RC is much better than RT. If you look at them, the complete response in TRBT, those are patients, in my opinion, will be eligible for both complete TRBT, excellent response in neoadjuvant chemotherapy patients are eligible for both the sections. But do we get patients like that in India? I'm not sure. I have to see a show of hands, but very unlikely. Trimodality therapy also has an impact on mortality. And I'm talking about contemporary publications. I'm sure Professor Ananya will agree on that. These are all publications came in 2020. All-cause mortality is higher, and bladder cancer specific mortality is also higher. Just because we have a recent spate of publication, especially driven by one paper from North America, doesn't mean we change the practice of what we have learned over the last 25 years. Survival after chemoradiotherapy. This is a BJU paper, by the way, from British. 1683 patients, and OS is much better in RC, and therefore concludes that RC is a more favorable treatment option for patients with bladder cancer. This is published in 2017. What is the survival outcome of patients with RC and bladder preservation protocol? This is retrospective, multi-institutions. I agree that this is not a randomized control trial. I agree with that. But in spite of it, survival is much better with RC. That is a fact. Okay. I completely agree with Professor. We don't have a proper RCT in this. And as Professor says, as Sanjay always says, it's impossible to do RCTs in this setting. We have to get what the data is available, and we have to conclude from what we have in front of us. Radiotherapy has an impact on quality of life. I agree that modern radiotherapy is much better than the old style cobalt which we all looked at in the past. I agree with that. But doesn't mean that radiotherapy doesn't have toxicity, yeah? The toxicity rates, we may say that the toxicity is comparable or acceptable, but the fact is that toxicity is not there. And recurrence after bladder preservation, that's the data in front of you. Yes, salvage cystectomy is 29% and 31% at 5 and 10 years. Look at the data, the distal recurrence, 32% and 35%. A proportion of that patient may not have had recurrence if they had the bladder removed. And if you have local recurrence after radiotherapy, you come back to salvage again. You're back to square one. And complication rates. Sanjay comes from Christie, same place where Professor comes from. And Sanjay vouches by the RCIC after for a salvage. But sadly, I come from Liverpool. And my patients don't do that well with salvage as much as Sanjay's patient does. It's a difficult operation. They are fraught with complication, very prolonged recovery, and it is not nice to handle those patients. I'm just going to quickly push on and say, bladder preservation. Dr. Ananya said, preserve your own bladder. You preserve your own bladder, which is small, non-functioning, or you get rid of it and have a pouch. That's a question. QOL, both TMT and RC. Is RC better than TMT or TMT better than RC? Needs a prospective evaluation, but the fact is that both are equivalent when you take it at 1 year. Cost. All patients with bladder cancer, especially in India, will agree that we need intense follow-up. 3 monthly cystoscopy. In Apollo, one flexible cystoscopy is 16,000 rupees. And if you take the patient to GA and do biopsy as prescribed by EAU, patient pays through your nose. Tons of money. Even in America, it's the same, leave alone India. So it's just a highlight to say that eventually by 1 year, the amount of money that you pay when you try to preserve the bladder is far higher compared to the fact that you lose the bladder just because there is a far better option for you. Compliance. You cannot do a TMT in a patient who is not compliant. My patient who comes from Tripura will get a radical cystectomy, go there in Tripura and does a video call to me. Much, much easier for me to manage and help that patient. So who is TMT for? In the GU meeting at Kolkata in India, it's meant for a very small proportion of patients. And in those patients, yes, I agree. They are good, they are equivalent, I agree. But that is a tiny proportion, sadly, in our practice. So we are still, from my Lakshadweep, I am still searching for that perfect patient in India. Sanjay, before I came up, asked me a question. Raghav, how many patients have we done? I said, 1. And that one patient is doing well. Latest publication, last month, yeah, Zolota. And read the last line, yeah? Please. In a multidisciplinary setting, offered for suitable candidates and not only for patients significant. So it is selection, it is case selection that matters. It is not a blanket thing. Can surgery be replaced in this era? Answer is no. It cannot be replaced. It is selected for patients, it is good, but it is very difficult to implement in India. You have to be quite sure about the cost And with the increasing amount of insurance being adopted in India, probable in the next many years to come, we can see some more patients being recruited into TMT arm. So that's all I have to say, Professor. In Kolkata, I think it's still difficult to implement TMT. Thank you. Any questions?
Okay. Professor Chaudhary,
Oh,
would you?
yes, you'd like me to rebut? Well, lovely talk, but a bit of cherry picking, if you don't mind me saying, when it comes to the data. The randomized controlled trials around the world for radiotherapy versus with a radiosensitizer included patients who didn't have maximal debulking, included patients with T3 and T4A disease, and therefore I think that it is untrue to say that those are contraindications. Those studies also included patients with CIS and hydronephrosis. So again, unless we want to do a prospective, multi-center, randomized control trial, those are all going to be subgroup analyses of subgroup analyses. Of course, overall survival is higher in patients who have surgery. They invariably are younger and fitter because they have to be fitter to have surgery. So I think my surgical colleagues cherry pick their patients just as much as anybody else does. And my final point is that actually there's data published last year from the UK for node-positive bladder cancer, comparing surgery with radiotherapy, and there is no difference in outcome. And that paper is in Journal of Clinical Oncology, first author Swinton, if you want to look it up.
Thanks, Prof. I agree. I appreciate that. In any debate is always one-sided, isn't it? Otherwise, there is no fun. Otherwise, I can't make all of them keep awake. Having said that, I completely agree with Professor. We will see a changing trend in the next 20 years to come with the advent of modern radiotherapy, and we start picking up more and more early cancers than the large volume cancers that we deal at this point of time. So yes, there'll be a shift in the next 20 years to come. Probably next generation after me will be seeing the shift.
Well, I have one thing to say add, because I do not want to take any side, though because I'm an clinical oncologist. So when I worked in NHS, then in UK, there is no competing interest between surgeons and radiation oncologists. So patient used to have the opportunity to discuss each modality. But in India, in private sector particularly, there is a competing interest. So, and that time also back in 2004, 2005, we used to say, maybe in next 20 years, we will resolve this issue, but that has not been done. So what my question is, because in National Health Service, you do not have a competing interest, so why we are not able to do a phase 3 randomized controlled trial in this sort of situation to resolve this issue? Is that the surgeons are not interested, or clinical oncologists are not interested, or both?
I think the patients aren't interested. I think the patients, as you said, the patients in our system already are empowered to make the right choice for them. They don't want a computer choosing a treatment. They want to pick the treatment that is most appropriate for them, whether it's a radical cystectomy or whether it's bladder preservation. And you're never going to change that, right? Once patients are empowered, you're not going to turn it back. It's the same discussion in prostate cancer, right? Who's doing a prostate cancer trial comparing, laparoscopic robotic surgery or open prostatectomy versus ADT and radiotherapy? No one. And yet we seem very comfortable, right, with accepting that there is equivalence in outcomes and we have to pick the right treatment for the patient. There's so many other cancers in which organ preservation is absolutely accepted. I have no idea why we keep having this discussion in bladder cancer.
Okay.
It's patient bias cannot be changed.
So the patient are the ultimate decider. Professor Ananya Chaudhary is also saying there is a bias. Being a surgeon, again, like Tanmada said, that he don't want to be biased. in RC versus RT, as Professor Raghavan said, in the Indian scenario versus the British scenario, we need to select it according to the presentation of the patient and considering the compliance of follow-up. That is the most important part. So this is something, it should be patient specific, and we should be, choice is always on, progress, RC versus RT, but time will unfold.
Thank you, sir.
I think we had a very nice discussion about this. I thank both of you for your presentations and discussions, and we close this session. Thank you.
Thank you,
Thank you.
Professor.
Thank you. Bye-bye.